Welcome. I'm Barbara Marcum, the Director of the Senior Resources Department for the City of Westland. With me today is Dr. Mehta, and she is an infectious diseases doctor from St. Mary Mercy Hospital. And we're talking today about C. diff. But first, let's talk a little bit about you. Infectious diseases is a fascinating field. What made you decide to pick this particular field of medicine?
I did my residency at St. John, and I had one of the best infectious disease physicians out there, and they had a profound effect on me, and I just realized it was great when we do a lot of history taking, come to the diagnosis, and we see the treatment, and it was a lot of investigation that we did, and it was very rewarding because you see the difference in front of you when you get the right diagnosis and you treat them. So it just was a great field where I learned a lot from those doctors, and I decided to just get into infectious disease at that moment.
Well, it's fascinating, and I'm sure a lot of people wonder, and I'm sure this is a question you get asked, because they're infectious diseases, are you ever worried about catching something?
No, not really, because you know what is going on, how to prevent yourself, and we take the adequate precautions. So I've never been worried about that. In fact, it's always been about getting rid of the infections and treating the patients.
Yes, and sometimes now with some of the things going on in the world, we need our infectious diseases doctors because there are new strains of things coming all the time.
Right.
Things that don't have cures may have treatments.
Right.
So I very much respect the field that you're in.
Thank you.
You're welcome. I have, as I talked to you before we did the show, my mother, I had a personal experience, and my mother got C. diff. And she had a stroke in June, and then it was something that we couldn't get rid of. And it was like, what is this? And so I had to do a lot of research on that myself, and I had a couple of seniors who have had experiences at my center. So I thought, you know what? I think this is much more prevalent than I think. So let's do a show on this because it took a lot of digging. So if you could explain to our viewers, what is C. diff?
Okay, so C. diff stands for Clostridium difficile. Clostridium is the name of the bacteria family, and difficile is the specific species of that bacteria. Mm-hmm. So the way it originated was in 1918, where people started having diarrhea because of different things, and the name difficile came about because it was so difficult to culture because it doesn't require oxygen. So it's one of those difficult bacteria in the laboratories. So that's how the name difficile came about. And it actually fits in really well from today's standpoint because it's difficult to get rid of as well. So it's like Clostridium difficile, that's how the name is. And what happens is that it's one of those bacteria that has the property to form spores. And spores are the way I kind of explain it to my patients is like seeds. They form these small dormant-like state with a shell around it that can resist the harsh environment. So even your regular cleaning surfaces will not kill it. So it's not killed by alcohol or
Lysol,
regular cleaning products. So it can stay in inanimate objects like all your floors, curtains, doorknobs, and everything. It can stay there for months. And that's how what happens is when you have patients who've had alteration in their gut flora, we call it microbiota, for different reasons, like either they have inflammatory bowel diseases, or one of the most common thing is where they've taken too much antibiotics.
That was my mother.
Yes, so what happens is that is one of those things we're making people more aware of, that when you take all these antibiotics, if they're intended for treating whatever infection, they also get rid of all the good bacteria in your bowels. And once that is gone, you can have all these spores that you can ingest, and they go into your bowels, and they attach to the receptors in the colon, and they produce this C. diff toxin, which precipitates and causes diarrhea and causes inflammation of the colon, and that's how you have the C. diff infection.
Well, for example, was on just a 10-day regimen for cellulitis. We
Right.
don't know what happened with her leg, but there was an infection there. And then all of a sudden, she had the C. diff, and we couldn't get rid of it. And then it was, and then there are the treatments, and she ended up with it 3 times. So let's go through what the treatments are. What is the first treatment? So initially, when you get C. diff, and you do know easily there is a peculiar odor associated with that, I noticed.
That's actually a myth because it's actually an odorless bacteria.
Well, okay, we knew all 3 times, and I'm not sure exactly why, and maybe it was something else.
Yeah.
But, you know, when she ended up having it the first time,
Yeah.
when she went in, she was in a skilled care facility,
Yeah.
and then we brought her home,
Yeah.
and then we had to take her back.
Right.
The C. diff it took probably 5 or 6 days after her first treatment to reappear.
Right.
So, what is the first treatment that they give you once you're diagnosed with C. diff? Now, they do a culture, I guess, a fecal culture. Is that how they know for sure?
Well, we do molecular tests, so we don't, because it's so difficult to culture because it doesn't require oxygen, so we don't send it for cultures anymore. We have these new assays which are called molecular tests. So they detect the toxin in the stool. So that's how we do it. So
Okay.
all it is detecting the toxin of the bacteria, not necessarily culturing it.
Okay.
So most of the hospitals in Michigan do that molecular test.
Right there at the hospital, or do they have to send it away? They can tell
Yeah,
right
in
away?
the hospital, in the
Okay.
hospital
Okay.
laboratories, and you get the answer within 24 hours,
Okay.
whether it's positive or negative. So basically, you're looking for the toxin. And if it is positive, if the patient is symptomatic, because you have to remember a lot of patients could be asymptomatic and carriers of C. diff, and they could have the toxin positive but not have any symptoms.
Now, I understand sometimes babies will test positive for C. diff.
Absolutely, and they don't get the symptoms because their colon hasn't have the receptors yet, you know,
Where the seeds
where the
would
C. diff
stick.
would attach. So they're still babies. So when they grow up, they can have those receptors and they can get symptomatic, but the babies are asymptomatic carriers. So a lot of times the mothers are the ones who get the infection because they take care of the babies and the diapers, but the babies won't get it.
That's fascinating.
Yep.
Okay, so then you test positive for the C.
Right.
diff, and what's
So-
the first thing that they do?
So we start with basic oral medication. So you have to actually take another antibiotic by mouth to kill that C. diff infection. So you have different antibiotics. So, and we start with Flagyl, which is a good antibiotic for mild to moderate cases. So you actually divide the cases as a mild, moderate, and severe. And I'm assuming with your mom, if it was the first case, it was maybe a mild case. And you start with a simple drug like Flagyl, and you give it for 10 to 14 days. And that's a standard course of treatment.
Okay. How often do people become reinfected after that initial first time?
So it's usually we say 20 to 25%. So it's like 1 in 4 patients are known to get reinfected, and it's only because this bacteria has the property to produce those spores. That is why what happens is either when you kill when you give the medications, you kill the bacteria, but not the spores. So the spores could have been remaining in your body, and once your treatment is done, the spores regerminate and cause that infection again. So that's why people get the infection, they have a tendency to get the infection again.
Okay, and also, I guess what I'd like to know is if they've been treated and the family, like us, we were cleaning everything with Lysol and this, we never used bleach.
Right.
And so we weren't killing the spores at home. Is
Right.
it possible that she was reinfected just by her home environment?
Well, I think more than the home environment, it's basically how good the microbiota of her intestines are. Because if you're living with her, it's not necessary, even you might be touching the same things that she's touching, but you may not get it because you've got a healthy flora in your intestines, and you can combat that C. diff bacteria. Whereas if her intestines are already altered, yes, she could be touching it and ingesting the spores again, and she unfortunately gets it just because her bowel flora is not as good as the others. That's
Well,
why.
I was worried because my dad is 90.
Right.
So, and he was home with her. I'm only there on the weekends.
Right.
So I was worried and I thought, I can't do this with both of them.
Right.
But anyway, okay, so she got it for the second time.
Right.
And then then they gave her a different treatment.
Yeah.
So what do they give you after you have the first treatment?
So we say that, so this is by guidelines. We have good guidelines that help us with this. So they say even with the first recurrence, again, if it falls in the mild to moderate category, you still go with Flagyl again. And it's actually proven for the first recurrence to give Flagyl again. Now, if you're talking that she's had the second episode, which is more severe than the first episode, then we go to oral vancomycin by mouth, and that's again another 10 to 14. That's what she had. So again, you classify the severity of the disease and take it from there.
Okay, just so the viewers are clear, when they classify it as mild, moderate, or severe, do they do that? What classifies it as mild? The number of episodes or how severe the symptoms are?
How severe the symptoms are. So when I talk about moderate to severe, you're talking about fevers, you're talking your pulse rate is high, you're having belly pain, your white cell count's really high, and you would have ideally a surgeon involved just in case it starts to become worse at any time. So we're talking
She did run a
moderate.
temperature the second time she got it,
Right.
and it was funny because she was very confused. She couldn't talk, and she was very weak.
Right.
It was like legs straight. She couldn't straighten her legs, and that was at night. And then at night when I got up with her to go to the bathroom,
Right.
I knew right away she's burning up. So
Right.
that was an indicator for me, but
Yeah.
that didn't happen the first time.
Right,
but
she
it
might
did
be
the
more
second.
dehydrated and everything with the diarrheal episodes, and that might have caused all that weakness and everything as well.
So now we're on the second time. So you give them the same thing you do the first time, unless it's more a severe case, and then
Right.
you get the vanco.
Right, we do the vancomycin.
Okay. So then, how many times do you treat with that if they get it again?
So again, I would start, so supposing if they've already had the vancomycin and they've relapsed on the vancomycin, at that point I start to do a prolonged tapering course of vancomycin. So not just 10 to 14 days, we're talking 8 weeks. And what we do, again, these are by guidelines where we do tapering courses. So if you're giving it 4 times a day, we do it for 2 weeks and then cut it down to twice a day, once every other day, once every third day. So the concept is that although you've killed the bacteria, the spores are still there. So what we're doing by giving tapering doses is that we are hitting the spores as they germinate. So that's why we give the tapering course, and that has been proven pretty effective in my patients. And there are times where they are like, can we just take it indefinite tapering till we feel better? So I don't just go by 8 weeks. Sometimes I even prolong the tapering and say, okay, let's just see how you do. And then when we're comfortable, we can actually stop and see how you're doing.
When I was looking at the symptoms, sometimes they said like a mucus or bloody. What is an indicator other than the diarrhea? What is an indicator that it might be C. diff?
So the way we say it is watery diarrheal bowel movements, period.
Okay.
So it's something like you've never had it before. We're not talking once or twice. We're talking multiple episodes where you just have this urgency and you have to rush, and it's literally water. And even in the hospitals, we say don't check for the stool samples unless it's diarrheal. So diarrheal is the critical symptom that we look for. So we're not looking necessarily for mucus or blood or something, but we're talking about just what I said, frequency. Not being formed, and we're talking watery diarrheal movements, multiple episodes.
Okay, so
Yes.
people are struggling with this, and they've gotten it multiple times. There is now a new procedure. So I guess the vancomycin then would be the second.
Yes.
Okay, and then if over the tapering course, there is a last resort type thing,
Right.
which is
The vancomycin tapering dose.
What about the fecal? Do they
So
do
we
the
have
fecal
another,
transplant?
before we go to fecal transplant, we also have another medication which is called fidaxomicin,
Okay.
200 milligram twice a day for 10 days. And that's on a little more on the expensive side, where a lot of the insurance companies
$1,200, I think
Yes,
it is.
yes.
And the
So-
insurance doesn't pay for that.
Exactly. So
And I
we've
think
had,
it's 50% effective.
it's
I
a hit or
heard.
miss, and
Okay.
again, so it's not like 100% guarantee. Otherwise, they'll be like, yeah, I'll shell the money out, you know. But,
Sure.
So yeah, again, it's not 100% guarantee. But I feel like before going into any invasive procedure, I want to make sure we've tried all the
Sure,
things,
anything.
all the oral medications, simple measures, and I also kind of focus on like obviously avoiding antibiotics during that time,
Yes.
and you know just washing your hands with soap and water and good hygiene. So those are the things I focus on before I say, okay, it's not, nothing is working.
You mean I don't have to, I've been spraying my hands with Clorox.
Oh my God.
And when I take care of my mom, I take every precaution, because when when you're in a facility, they garb up. You know what I mean?
Yeah.
Everybody's got all of the
Yeah.
infectious diseases thing, the
Yeah.
gloves and the masks and the gowns, which is a little bit frightening sometimes when you see that. So I've been very careful.
Yeah, but that's only because you have to remember there are more other
Multiple
sick
patients.
patients there,
Yes.
and they're taking care of the other patients.
Yes.
So theoretically, we're trying to prevent as much as we can transmission to other patients who are more sicker. But practically, I don't know how much it is really effective, because you have to think they are everywhere, and we don't know how much is. You can't be looking at everything and saying it's gone or not.
No, and in an environment where you have so many sick people, like this, like you said, the spores or anything where a small amount touches this or that, I mean, it would be hardly able to control it.
Exactly, and it's persistent for months, so you don't know what you're touching. It's actually more prevalent than we think it is, just around us on inanimate objects.
Now, I have a question. I'm not sure, yes I am, what she was taking. She was on clindamycin, I think.
Okay.
And she was on a 10-day
Yeah.
regimen, and it was after that she got it. Is there any particular antibiotic that they think is responsible for that, or is it all antibiotics can cause it?
Yeah, most of the any antibiotic can cause it.
Okay.
And clindamycin is notorious because it kills the anaerobic bacteria, which is the class of family that this bacteria belongs to. So we're talking fluoroquinolones, penicillins, cephalosporins, all of these broad spectrum antibiotics can cause C. diff infection. So it's just historically clindamycin has been notorious.
I was wondering, because a couple of people that I talked to had a problem. That was the antibiotic that they were taking, and then they got the C. diff after that. Okay, now I also, and correct me if I'm wrong, it also has something to do with the length of time that you're on it. So she was on a 10-day regimen, and I guess the longer you're on an antibiotic, the more chances that you kill all the good flora and everything. And
definitely, I mean, the longer you are on, you're killing a lot of the good bacteria that is helpful in maintaining that healthy environment in your bowels. So absolutely, the length of period, the more broad spectrum antibiotics you take, and a lot of them plays a role in washing away all the good bacteria in your bowels.
It's interesting, because people look at antibiotics like, I'll just take an antibiotic, or there's been lots of shows on doctors, because you don't know if it's viral or bacterial,
Right.
so
Right.
write an antibiotic. And we were talking about indiscriminate antibiotic use, and then all of a sudden now this is a big problem, and especially for seniors who are compromised in so many other ways.
Right, exactly.
But one of the people at my center, it literally affected her life for 2 to 3 years.
Yeah.
And so if someone is a senior,
Yeah.
would you say, okay, if there's a problem, can we not do the whole 10 days? Can we try to move it to the
Absolutely.
3 to 4 days instead?
Oh yeah, I'm any infectious disease doctor that you talk to, we are very, very conservative, and we are like, okay, if it's just simple cough and colds and all that, please do not take antibiotics.
Right.
We are big time because we see so much resistance, even besides C. diff. There's just so much menace of taking too much antibiotics. So we go out there and say yes. So start with simple ailments. You can do a watch and wait period, see how you're doing, instead of popping pills and
Right.
antibiotics. So stop right there. And if you have to, definitely start saying, can we take a narrow spectrum? Can we shorten the duration of antibiotics? So supposing if you have a urine infection or something, if your symptoms have resolved, stop the antibiotics. If you have cellulitis, if you feel like the infection's gone, stop it. Just because your doctor said take 10 days, you need to reevaluate and have a discussion and say, well, my symptoms are gone, can I stop it? So definitely go on shorter duration and as much as possible avoid it.
Yeah, it's funny because I have always felt that I never even gave my children Tylenol unless their fevers went way up there, like 104.
Right.
If it was 1 or 2 or even 103, it's like this is your body's way of killing this bacteria. This is good.
Right.
And you don't want them to lose their hearing or have a problem.
Right.
So when it gets real high and dangerous, that's one thing, but it's like this is your body's natural response to an invader.
Right.
Let nature take its course. That's how we build. That's how we're strong.
Yeah.
And so with antibiotics, people don't realize there are only a certain number.
Yeah.
They don't just keep coming up. So once you only have so many antibiotics, the best is not to take them unless it's absolutely necessary.
Right, like especially with the flu season coming, everybody has cough, cold and everything. And even if they have fevers, I say wait for 7 days before you say there's anything else going on. So like even my own sister, she'll be like, I'm going to die. And I'm like, well, okay, wait for 7 days. Let's just
If
wait.
you're still alive, then we'll talk.
We'll talk, yeah.
Okay, well, okay, so if at the last resort, I know they do fecal transplants.
Yes.
Now it was funny because down in Oakwood, I'm getting this from one of my senior friends, that finally it was so bad that they ended up, now I guess they have an oral pill that they use now.
It's a frozen pill. You can put it in your fridge.
And they actually took like an NG tube and up through the nose, and you have to have a donor who's in the family. And the doctor said just the idea of fecal material going down your throat, people would pass out, they would vomit, and so they ended up, now there's an oral pill and they also do it like a colonoscopy.
Yes.
So as a last resort, if you just can't get, and I guess with the senior, if you got it that many times, the dehydration could actually probably be life-threatening if you're in that bad of a state.
Yes. Absolutely. I mean, it is one of those last resorts, yes. We start, and it's proven very effective. We're talking 90 to 100% effective. And yes, we ask the family members to be the donors because you're in the same environment, so you have the same flora that you have within the family. And I think colonoscopy is better than the NG tube and even popping pills because yes, the idea is pretty gross, but at the same time, if it saves life, that's what we need at that point. If it's
and people who have had C. diff and can't get rid of it, they don't care about that.
Exactly.
They're so thankful that they're getting rid of it that it's like, thank you.
Yeah, no, because we're talking after that, we're talking just removing your bowels. So you're talking colectomy at that point.
Seriously?
Yes. Because if you keep having C. diff, you're having more and more inflammation of the colon, and at that point you're worried that it can perforate. So when we have severe C. diff patients in the hospital, we always have a surgeon on board, and we are always very careful. Are they getting into toxic? We call it toxic megacolon, where the colon becomes so big because it's so inflamed that it can perforate any time.
Sure, I never thought of that.
And yes, and that's so. If you're talking a patient who has to save his bowels and get a fecal transplant, so be it, because then we're talking about colectomy, really.
So then what happens? They remove that, and then
and then you anastomose the small bowel to your rectum because the large, and it depends how much of the bowel they're going to remove and all those things. So,
sure.
Yeah.
Wow, that's really fascinating. So, I mean, so you said it was what, 1918 that they first realized what this was?
They discovered the bacteria.
They discovered the bacteria because I was reading something about in the 80s then they had like 15,000 people ended up dying from that, and then it became, I guess, more of a public health concern.
Right, and then we have these really more toxigenic strains of C. diff. We call it hypervirulent strains, which actually cause more severe infections than the regular C. diff infections.
Really?
So yeah, so you don't want to have the bad strain of C. diff, and that's what we discovered in 2000. It was called the nappy strain, where we noticed that patients were just dying of C. diff, which was never heard of in the past, because yes, you get diarrhea, you get medications, you get better, but we did these studies where they found that there was high morbidity, mortality of these patients, and that's when we started doing, again, more research and testing, and we found this strain, which is the hypervirulent, more toxigenic strain.
Okay, then now I have another question. So the more virulent strain, would that be caused by putting, I guess, just like, viruses when they mutate, would this be like a mutation of an original virus?
This is a bacteria.
I mean, a bacteria.
Yeah, so you have different strains, and it's in the environment, so we don't know how it became this hypervirulent super bug that we call it. So we're not sure about that, and I think it's just something that we discovered. And again, if somebody had C. diff, I would have to send it to like an outside tertiary care center to say, is this that strain? Because it's all research based, you know. So at this point, we just say, is it a severe C. diff infection, and treat it. But yes, research has shown that there are some strains that are more toxic.
Now see, I love doing these shows. Okay, I have a couple more questions since our time is almost up, but could you explain to what MRSA is? Because a lot of people are very concerned with that. It's very prevalent. What is MRSA, and should people be worried again about the indiscriminate antibiotic use?
So MRSA stands for methicillin-resistant Staph aureus. Okay, so let's break it down. And Staph aureus is a bacteria that lives on our skin. Mm-hmm. So it's a common pathogen. It's just that when you take too much, what has happened historically, that simple staph bacteria, you could kill it with penicillin. You're talking 1960s. But once we started overusing penicillins, they became resistant. So most of the Staph aureus is resistant to all penicillins. So then they came up with these special penicillins called anti-staphylococcal penicillins, and one of them is methicillin. And that used to work for Staph aureus until that became resistant. So that's how we came about with this term called methicillin-resistant Staph aureus. That's MRSA. So in a nutshell, it's basically a Staph aureus that is resistant to a lot of the antibiotics. Again, yes, it boils down to that thing that you should be avoiding a lot of the antibiotics, but you have to remember it's a common bacteria that can be living on your skin. Mm-hmm. And unless you have symptoms related to the Staph aureus, you don't start taking another set of antibiotics to kill that Staph aureus.
Well, this is all very fascinating to me, and I thank you so much for coming on, because I was so worried, and I'm online, I'm researching for hours, and I'm thinking, if I have to go through this, I want to save, our residents and people who end up dealing with this in their own life,
right.
To know a little bit about it and right. what they can do to prevent it, right. what kills it,
right.
and again, I always stress the antibiotic use.
Yes.
Don't take antibiotics.
I think this is a great platform to stress
yes.
just that,
Yes, and I think, yes. There's only a certain number of antibiotics, and once those don't work, nothing works.
Right.
And then we are in deep trouble.
Right. You're spot on.
Yes, thank you so
Thank
much.
you.
It was a pleasure having you on our show.
Thank you.
Thank you. And thank you, friends in the viewing audience, for being with us today.